Hello, everybody. Thank you for joining us today. If you're just joining us, please feel free to put your name, say hello in the chat and where you're from. Um, welcome to today's webinar. When doing nothing is the greatest risk, an evidence-based cleansing method in wound care can offer protection for your neonates. This webinar is sponsored by Ergo Medical, featuring Vashe, a pure hypochlorous acid preserved cleanser. And I'm pleased to introduce our speakers today, Dr. Rene Amaya and Carol Marshall-Hanson. So first up, Dr. Amaya earned his medical degree from UT Southwestern Medical School in Dallas and completed his residency in pediatrics at Phoenix Children's Hospital Maricopa Medical Center. He then returned to Texas for a 3-year fellowship in pediatric infectious disease at Texas Children's Hospital Baylor College of Medicine in Houston. Board certified in pediatric infectious diseases by the American Board of Pediatrics, Dr. Amaya expanded his scope of practice in 2013 to include pediatric wound care. He currently provides hospital-based consultations in both pediatric infectious diseases and pediatric wound care across 5 hospitals in the Houston area, and he serves as Director of Infectious Disease and Wound Care for the Pediatrics Medical Group Gulf Coast Division. Dr. Amaya is a board member of the International Society of Pediatric Wound Care. He's widely recognized for his research in complex pediatric wound care, focusing much of his work on neonatal wounds. He has authored numerous scientific abstracts, peer-reviewed journal articles, and textbook chapters, including contributions to both editions of Neonatal and Pediatric Wound Care. He's also a frequent speaker at national and international wound care conferences and seminars. And outside of medicine, Dr. Amaya maintains a balanced lifestyle through yoga, Pilates, and swimming. And he is a certified yoga instructor. Welcome, Dr. Amaya. Carol Marshall-Hanson is a master's prepared registered nurse with 46 years of experience, including critical care, regulation, and wound ostomy continence nursing. A certified wound ostomy nurse, she has served as a WOC nurse at Dell Children's Medical Center, as Dr. Amaya mentioned, of Central Texas for 18 years. Located in Austin, Texas, Dell Children's is a 310-bed acute care facility with a level 1 trauma center, level 4 NICU. Carol's practice extends to an additional 36 beds at Dell Children's North, as well as 1 level 3 and 3 level 2 NICUs within the Ascension Seton network. She's presented 17 posters at wound care conferences, 8 of which have related to use of pure hypochlorous acid in neonates and pediatric patients. So thank you, Carol, as well for joining us today. And then with that, I will pass it back over to Dr. Amaya to get us started.
Great. So that's my ugly mug, and there's Carol with her great smile. So what are we going to talk about today? So our learning objectives. We're going to identify the hidden risk of common NICU cleansers. We all have a dilemma. I can see from the chat screen that everyone's from literally all over the United States, and lots of people from Canada as well. So I know there's always the dilemma as far as what can we use safely in babies to as cleansers as well as for wound care disinfectants as well. We're going to describe the safety, effectiveness, and clinical evidence supporting pure hypochlorous acid. We're going to analyze real-world case studies that I've seen in my practice, as well as Carol's in her practice as well, for improved healing outcomes, and discuss some implementation tips that we both use for our patients. And then we're going to review some neonatal research that I'm doing, specifically regarding Vashe and hypochlorous acid. So as many of you are well familiar, babies are very different from adult patients when it comes to skin. And even babies alone, when we go to wound conferences, the majority of patients in those wound conferences are all adult patients. But then you have your babies, and they kind of lump us all together, saying, oh, babies are the same. But as you well know, a 21-weeker is very different from a term baby with regards to their ability to heal and their skin. And this kind of graph illustrates that starting from the stratum corneum, which is the most outer layer of the epidermis on the skin, is extremely non-existent, or in premature babies going down to 23 weeks and younger, it's really non-existent. That's why frequently, whenever I see these babies that are in that age group, it's very common for me to be consulted on irritant contact dermatitis of the tummy or just general skin desquamation because that epidermis is so fragile and it's coming off and it gets very irritated, especially with umbilical care placement and management of those lines. So when you get a little older, the 26-weekers only have a few layers of stratum corneum, and it's not until you get to more your term babies where the full layers of the stratum corneum are there. So the younger babies, the premature babies, really have a weak and immature stratum corneum, which does so many roles in protecting these babies from infection. The epidermis as a whole, stratum corneum is part of the epidermis, but the epidermis itself is about 20% thinner compared to children, adults, or in term babies. And then the dermis itself is also not as well developed compared to older babies and children. The collagen is less effective, and the reticular layer can be partially absent, meaning the composition of mast cells, veins, arteries, etc., within that layer of the reticular layer of the dermis is not as well matured as in older babies. So we have a baby, the younger you are, the more likely that you're born with an immature outer skin layer. So that's the underlying problem. So we basically have an immature layer that's supposed to protect the baby from pathogens and to keep skin intact. So the skin is fragile and easily traumatized. So then what do? Well, we put these babies in isolates to regulate their temperature. And as I've seen in many cases, unfortunately, sometimes these isolates become prone for infections themselves. And I've seen many cases of infections that arise as a result of contaminated items within the isolates. My job previously as the infection control director was try to get as much thing out of these isolates that were not guaranteed to be sterile or washed routinely because those were leading to infections and hospital-acquired infections because the isolate itself was not the cleanest environment. So then we get infections because they're in an environment for many weeks until they can become in an open crib that promotes them to have higher risk for infections. And then so you say, okay, well, what can we do to prevent such things from happening? Well, unfortunately, antiseptics that are used in older children and in adults to protect the skin and reduce the bioburden from arising aren't as safe in these young premature infants. So we have a problem with them being toxic or not necessarily approved or unsafe, basically, in these young infants. So we have limited options available for us. The Association of Women's Health, Obstetric, and Neonatal Nurses came out with their last guidelines and talked about the role for skin cleansers. And the skin cleansers are basically an item that's meant to emulsify oil, dirt, or microorganisms on the skin surface so they can be easily removed. Ideally, in a perfect world, we want these cleansers not to cause skin irritation, not to disrupt the normal pH or the microbiome of the skin that was protecting these babies, as well as to not be irritating or cause irritation, specifically of mucous membranes in the eyes. You'd want to have a cleanser, ideally, that was neutral or mildly acidic, and that would have a minimal impact on the baby's own natural skin pH. Because the lower pHs, as we'll discuss soon, actually improves the ability of the wounds to heal or the skin to be protective and be a barrier to microorganisms and infections from arising. So ideally, we want to choose cleansers and preservatives that have demonstrated safety and tolerability in newborns and neonates, as well as the younger premature infants. Recognizing that the pH and chemical content of water sometimes itself can be a potential irritant to the skin, especially in these tiny, tiny babies. So then we're stuck. Are we dealing with items that are ability to be safe, such as saline and sterile water? but has no proven efficacy against the ability to protect against infections, versus do you use products as cleansers that are known effective towards killing various microorganisms such as yeast or bacteria, but are contraindicated in neonates because of the skin toxicity and the risk for allergic reactions to these products. So we're kind of stuck. So when you look at traditional items that have been used in adult wound care and in pediatric wound care in older children, the typical examples we typically discuss are Dakin solution, saline, chlorhexidine, and in rare occasions, mostly in the adults, acetic acid. So when you go to the top evaluation, so is Dakin solution, the safety of Dakin solution is always at risk. Because the pH of this product and this product line tends to be a little higher and rather more alkaline, and increases the risk for toxicity to the skin and cells within the skin. Is it effective? Of course, Dakin's an amazing product. And when I worked in various third world countries with limited access to certain products, I mean, in the adult population, we use Dakin's all the time. So is it effective? Yes. But in babies and neonates, that would be a concern, especially when we're talking about the pH of the skin. Normally, we'll talk about that in a second, but normal pH of the skin roughly goes between 5 and 7. So when a Dakin solution was extremely alkaline, it's really not going to provide that type of healthy environment for the skin surface. And definitely no guidelines recommended for use in neonates as standard of care using Dakins. When you talk about saline as another opposite extreme, is it safe? Of course. There is no evidence to suggest that saline causes any type of damage to these young babies. But is it effective toward antimicrobials and yeast? Definitely not. There's no evidence at all that saline does that. Is it safe for the human pH? Of course, saline is pH neutral. But are there any guidelines specifically for the use of saline as a disinfectant or a cleanser per se? Definitely nothing right now with regards to the efficacy of saline towards an anti-infective cleanser. Chlorhexidine safety is always a concern, especially as we go toward younger infants. There's always a need to wipe and to irrigate skin after using chlorhexidine because of the fact that it can be cytotoxic. And depending on the percentage of chlorhexidine used in infants and neonates, there's always a risk for complications that might arise. Is chlorhexidine effective? Of course, once again, another product that has proven efficacy toward microorganisms, but is it safe for the pH of skin? Not necessarily. And are there any specific guidelines for various concentrations of chlorhexidine in infants? Well, we do have standard recommendations per se that we use less concentrated form of chlorhexidine mixed with alcohol, but for general, still the concerns are for the safety of these. And there's many examples that I've mentioned earlier, alluded to earlier, when chlorhexidine is used on the abdomen for prepping umbilical sites, that I'll get called in a day or two later with complete irritation and skin breakdown because the chlorhexidine wasn't effectively wiped or diluted with saline or sterile water afterwards. Acetic acid is on this list. It's a product used primarily has been used in adults. Definitely no evidence to suggest safety or efficacy in babies. It definitely kills bacteria, but extremely cytotoxic to healthy skin cells and has to be used very cautiously. I would keep that. With so many other options out there, I would definitely keep acetic acid off the table with regards to use in infants and pediatrics. So then talking about, this is a slide reviewing the efficacy of safe products such as soap and water, saline as an antiseptic or anti-infective. And the graph you see there on the left side of your screen shows that a non-antiseptic products such as saline, soap and water actually promotes more bacteria to grow in that skin and or wound environment, as opposed to antiseptics. So safe products aren't necessarily the most effective with regards to reducing bacterial load. The other photograph on the right, photograph looks like an adult patient, but the point is to illustrate that before and after cleansing, there's a product on the market right now that can use fluorescent lighting to take a picture, and you actually see the bacteria growing in a wound bed. And this shows that before cleansing and after cleansing with standard just cleaning the wound itself with a simple non-antiseptic product actually promoted or allowed these bacteria to actually grow even further and be more prominent within the wound bed itself. So therefore, we're stuck with safe products aren't necessarily the most effective towards an antiseptic or killing environment for preventing infections from arising. So multiple guidelines by National Pressure Injury Panel, JWC, Journal of Wound Care, consensus guidelines, International Wound Infection Institute, Wound and Tissue Regeneration, Wounds International, multiple guidelines and official organizations in the wound care world have promoted the use of an antiseptic for cleansing wounds and protecting skin from getting infection from arising and for promoting healing of these wounds. So it's definitely a high level of evidence that we need to use something to keep our wounds clean, reduce the bowel burden, reduce the risk from infections, and to promote a wound healing. So therefore, how can we recognize that there are gaps? So definitely, we see that there's limited evidence, as we've discussed, that saline itself disinfects and actually may lead to increased levels of microbes and bacteria. Using a cleanser that can remove or disrupt bacterial and microbiology colonies is really an important factor. So is reduce the risk from infection to arise in a wound, as well as to promote healing overall. Because if a wound becomes infected, then the healing rate is going to be much more complicated and slower. The ideal cleansing solution should balance the need for removal of microbial colonies while avoiding damage to the underlying healthy cells. So you have all these healthy cells that the body is sending to and recruiting to the site to heal the wound, only for your cleansing product to be potentially cytotoxic and kill them all. And then you're just stuck in this loop of a poorly healing wound that nobody really wants. And then finally, as we pointed out, traditional cleansers such as hydrogen peroxide, definitely nobody should have. That's a separate lecture, but nobody should have. If you have hydrogen peroxide at home, please throw it away in your house. Traditional sodium hypochlorite, which is Dakin solution, providone iodine like betadine and chlorhexidine are proven to be cytotoxic to these healing cells, these rescue cells, these first responders that are going to the wound, the body's first responders that are going to the wound to heal them. And all we're doing is applying something that potentially damages them and impedes healing and closure overall. So here we have then all this dilemma that we've talked about, non-antiseptic versus septic, simple versus non-cytotoxic. And then here we go with pure hypochlorous acid. So hypochlorous acid meets the standard of care for all those things we discussed already, meaning is it safe? By all means. Excellent studies out there in the adult and pediatric world, and in some smaller cases in neonates and infants to show that it is safe for use, and these are non-cytotoxic to these first responders and healthy cells that are coming to the aid of the open wounds. Is it effective? Yes. We'll show shortly that it is effective toward many and most all antimicrobials that are present in the wound bed and can cause trouble. Does it affect pH? Yes, by all means. The pH of hypochlorous acid is designed specifically to mimic that of the skin and promote wound healing. And are there guidelines to suggest that hypochlorous acid should be used as a cleanser and recommended as a cleanser? That by all means, yes. There are excellent resources out there to suggest that hypochlorous acid is a safe and effective product to be using on wounds and skin to help heal and cleanse them of antimicrobials, of microbials rather. So this goes back to my original infectious disease days, but I actually did studies on opsonization of white cells of bacteria, and I remember using my pipette days and my microscope days in the lab studying this exact problem and how white cells kill bacteria. And actually, when pathogens are absorbed into the cells and white cells attack these bacteria and microbes to get rid of them naturally, hypochlorous acid that's actually generated within the white cell. So this is not something that we created in a lab per se and say, hey, it should work. The body itself makes hypochlorous acid. So we've only mimicked what naturally occurs within the body. So that alone supports the safety and efficacy of this product that we've been able to create. Once again, so it's proven based on these studies that pathogens are destroyed by hypochlorous action. So talking about the safety of it. So let's talk about safety of pure hypochlorous acid compared to other products. We talked about these first responder cells that are going to your wounds and your skin that are trying to help close these and reduce the irritation and the contact irritation from the keratinocytes and the fibroblasts. And when you check the safety of pure hypochlorous acid, definitely there is no evidence to support that causes any detriment to the first responders going to these open wounds, and it does great against them. No harm at all to these natural cells that are promoting healing. Same thing would go for saline. We've already stated earlier, there's no cytotoxic effects of saline on these cells that are promoting wound healing. Very contradictory when we're talking about Dakin solution or chlorhexidine, hydrogen peroxide, betadine in various concentrations. All these definitely have evidence to support there is some cytotoxicity and damage to healthy cells that are within the wound bed that are promoting healing. So among all of these, the only safest ones are pure hypochlorous acid and saline in this graph. So when you let's talk about the ability to fight bacteria. So when you plate out these bacteria and you apply hypochlorous acid to these bacterial colonies, it does an extremely great job at killing these bacteria. So you don't have to be an ID doctor to recognize the terms of E. coli, Staph aureus, MRSA, Klebsiella, from every different type of bacteria that has been utilized or affects human skin and wounds. Vashe has excellent outcome with regards to killing these bacteria. And it only takes a little bit of time for these for application of Vashe to the wound bed to kill these germs. So we'll talk, Carol will talk, and we'll talk about a little later on how it's actually applied on these wounds, but applying it on a gauze and keeping it on the wound bed on my perspective, for about a minute does an amazing job. So many of you the first question the medical student or the nursing student will ask me at the bedside, so why doesn't the infection go away altogether? Well, the skin and wounds bioburden and bacteria will actually grow back. Thus, the role for reapplying. So every time you apply that, you bring that bowel burden and the amount of bacteria down to a healthier level that's controlled both by the body itself and by the topical anti-infective agents that you're putting on the wound bed, whether that be a dressing or another agent. So this is definitely an excellent component toward fighting various bacteria, fungi, or viruses. So, So it has the ability to kill them in short exposure. Though a very important thing, there is no sense of resistance to this anti-infective cleanser. So as we well know, the problem with antibiotic therapy these days is resistance of bacteria toward these antimicrobial agents. Vancomycin, cefepime, ampicillin, gentamicin, etc. Those are what we run into every day. But with regards to hypochlorous acid, there's definitely no evidence at all has been proven to show any type of resistance from Vashe toward as a result of these bacteria present. So no resistance at all. Talking about wound healing and pH. So we've addressed safety. We've addressed the ability to kill various bacteria and fungus and viruses. But what's the importance of this pH? Well, the skin's pH normally resides roughly between 4 and 6, slightly acidic. If you remember that neutral pH is roughly about 7. So the healthy skin is a slightly acidic, and that's for multiple factors. That's mostly as a protective effect toward bacteria and various microbials that would potentially invade. So when we're dealing with open wounds and chronic wounds, especially chronic wounds, tend to become more alkaline. And that leads to further problems associated with the chronicity of these wounds. Your adult patients with these chronic venous ulcers, these pressure ulcers that are slow to heal. The majority of those are definitely in an alkaline or high pH environment, and thus promotes poor healing. So when you think about it, when Vashe or hypochlorous acid is designed to be specifically in a healthier, more acidic pH, you only change that wound bed environment and skin environment back to a healthier pH. So it promotes ongoing healing at that pH. So another advantage of having a product that not only will be safe, not only will be toxic to the microbials, but also focus more on healing the wound itself and promoting wound healing. So in the little bio, I've been lucky enough to write 2 chapters in the standard textbooks for neonatal and pediatric wound care. And on the second book that just came out in 2025, I was assigned to do the chapters on dressings on infected wounds. So in that chapter, I discussed the various products that we use as anti-infective dressings to include silver, iodine, honey, etc. And in that chapter, I talked about the role for hypochlorous acid. And my summary was that that hypochlorous acid, as we've already discussed, mimics natural antimicrobial properties that is naturally produced in the body and white cells toward invading pathogens. It has a broad spectrum of activity and no resistance, as we've mentioned, against the bacterial bioburden on the wounds and the skin. It is non-toxic to healthy skin cells and these first responder scale cells, fibroblasts, and keratinocytes that are coming to help aid and heal the wounds. The neutral pH of hypochlorous acid promotes a favorable wound healing environment, as opposed to other products such as hypochlorite solutions and propanone iodine that can actually be cytotoxic in open wounds. It's non-irritating and makes this very compliance favorable, especially when you're dealing with children who flinch at any type of wound management. And we've all taken care of these toddlers, or if it may not be your patient, but it could be your son or daughter who trying to manage their knee scrapes or cuts or burns. And the application of hypochlorous acid is actually non-irritating and does not cause any type of burning sensation on them. And babies and neonates tolerate it quite well. And lastly, we'll touch about this later on, but there are no adverse side effects so far have been seen, even in extreme premature infants. So putting it all together, Vashe is the market leader in pure hypochlorous acid that's available on the market right now. It's the #1 hypochlorous acid solution in US hospitals. It's the #1 branded cleanser in US hospitals. It's proven in multiple peer-reviewed journal articles regarding its safety and efficacy. And it's been around for 10 plus years. I remember seeing the booth and some of the wound care conferences in the very beginning. And actually, I always feel proud of how well that company has done over the years, and started out as a small, tiny little booth to the market leader they're at right now, only because of the fact that they have an amazing product that's safe. And I wouldn't be promoting any product unless it was safe in my babies. So think right now we're going to switch it over, and we're going to let Carol take over and review some of her clinical cases that she sees at adult children's.
There we go. So as you can tell, if you look at this first slide here on why we feel like at adult children's that Vashe is safe to use on neonates and children, you can tell that Dr. Amaya and I came up with our slides independently, and they all say the exact same thing. All the reasons that Dr. Amaya has just presented on why pure hypochlorous acid or Vashe is safe in the neonate and pediatric population is why we've now used it without any adverse effects for almost a decade. A couple of the things that haven't been presented yet are from a bedside staff standpoint. What makes it a great product also is there's no dilution, no rinsing, and no waiting. You don't want to dilute it because it's already diluted. I've had staff initially who were pouring it into bath water and thinking it was like bubble bath and they were doing a good thing. Don't do that. It's already diluted, just like it is coming out of the bottle. You want to leave it just like that so that it has its maximum efficacy. There's no reason to rinse it or wait for it to dry like in chlorhexidine. That molecule is going to be gone in a matter of a few minutes. It's not leaving any residue behind, so there's nothing to rinse off. So that's really important when we have our neonatal population and we're trying to prevent transepidermal water loss and hypothermia. The fact that you can do what you need to do and you can warm it and then you can immediately dry the skin after the time period that you've used it for and move on. We didn't always have guidance on warming Vashe. That was something that Ergo came out with a few years ago. They studied it because we were all asking for it, and we now have that guidance, which is that it can be warmed up to 43 degrees Celsius or 109 degrees Fahrenheit. Certainly, we're not going to warm anything maybe that much, or certainly would be less than that, warming it for a neonatal population. The left in the warmer for 7 days may be geared in some instances to the operating room in their wound care warmers, solution warmers, and outpatient settings. But in the NICU setting, we're thrilled because of our isolates with the warming factor for those really premature infants. We can take a 4-ounce bottle, date it and time it, and put it inside the isolate, and then we can use it on that infant. It's going to be the same temperature as what the infant is in, and we can leave it in there until we've used that bottle up within the 7-day time period. All right, let me see if I can forward now. Okay. We have used this on probably every skin and wound issue I can think of in the past 10 years, and it's used across all of the specialties that I'm aware of. There's truly not any specific situation or diagnosis that I would say, oh, don't use Vashe for that, it might hurt them. No, literally, this is on almost all the PAR units in all of our units. And a nurse can grab that and use it on anything that they're concerned about and while they're waiting to get a hold of somebody. And we know that they're not going to cause any kind of harm. No matter how bad the skin looks, It's a very soothing solution when you put it on an infant who's crying and their skin looks really bad, or on a child who is getting pain medication. In addition to that, we have found when we put the Vashe on them, they really calm down, and they say that it feels much better. And the ones that are highlighted there are the ones that we've used in the neonate population. Okay. This is one of the cases that we presented in a poster at the 2022 WOC Next conference. This is 23-week-old baby that we were called on to consult when they developed this lovely fungal lesion on their back, and they had a little bit, I believe, on their chest. Obviously cultured out that it was fungus, certainly had infectious disease involved doing the systemic treatment, but they're all very concerned going, what can we put on this very young infant with skin that's not totally developed yet? And I said, the only thing we can use on them is Vashe. A couple of things I want to pause and point out here is this twice a day, 2-minute soaks with the pure hypochlorous acid. When you're doing a baby that's minimum stimulation, obviously you don't want to do a lot of stuff to them. So you want to consolidate what you're doing. So doing it just once a shift, we found to be very effective. Also very important, whether you're using it for a diaper rash, a fungal rash, a wound, that you want to use enough of the product. So, you know, make sure your staff understand they can't just pour a little dab on gauze and pat it on the skin and have effectiveness. You have to really saturate your gauze. You need it to be almost dripping or dripping wet. Remember, you can warm it. And then you want to put it on that lesion or the skin and let it stay there. The 2 minutes is our time frame that we've developed and come up with. Where did we come up with that? If you remember the slide that talked about the antimicrobial effect in the 15 seconds or less, even on the multi-drug resistant organisms. So we took 15 seconds and we quadrupled it and said, we're going to leave Vashe on there for at least 2 minutes. Now, if you want to leave it up to 5 minutes, you can. If you're in a situation where a child or an infant can tolerate it and it's a really bad lesion that you think needs that extra, but you would need to put clean and fresh Vashe on it after that, because again, the molecule is going to be gone after a few minutes. Again, we don't have to wait for it to dry. We patted it dry. On this infant, we just laid, I believe, a silver foam, silicone-based foam over it. No ointments, no creams, no nothing. We just did the Vashe and put the silver foam on it that they could lay on, but there was nothing wet over this. And the systemic, of course, treatment also helped. You can tell that this is an older slide because it says we put the Vashe in a plastic bag and the gauze saturated with the Vashe and left it in the isolate for a couple of hours. That was because we didn't know then if we left it there all the time, if it would deactivate the Vashe. But now we know that we can leave it in the bottle itself and leave it in our isolate for up to 7 days if we need to. Okay. Diaper rashes by whatever name. It used to be incontinence associated dermatitis. Now the latest ICD-10 code is irritant contact dermatitis related to stool or urine incontinence. This is just one example that I use here because this was a father actually who sent me all of these. He had a medically complex infant, as you see here, who was on multiple drugs and rejection drugs, and they had changed one of his rejection drugs. And you can see how he has what I call this enzymatic erosion here, because he developed severe diarrhea when they switched his medication. And the father called me and said, I've been working on this for 2 months and I really can't ever heal it. And he's in great pain. And I just don't know what to do. So I told him what we had already started doing. This is back in the early days. When we had something that looked really bad, we would soak it for 5 minutes once a shift. And then the rest of the time, we used either a peri bottle or a little like travel spray bottle, not an aerosol, but just a little travel spray bottle that you can adjust and make it spritz very big droplets, because you want to concentrate the Vashe on this. And they would use the peri bottle or the little spray bottle with every diaper change so that they could do a water wipe and clean. And then they would spray some Vashe on there, leave it on 30 seconds to a minute, pat it dry, and put more barrier cream on. And then just twice a day or once a shift, if you're in a hospital, then they soaked it when it was this severe. And then they were able to back off as it improved, and you can tell it improved very rapidly. And this is now part of, we have a diaper dermatitis algorithm that we utilize. And again, the staff can jump in and grab Vashe in any time that they want to use it on a diaper rash that they're concerned about. All right. So central lines, one of the things that as wound ostomy continence nurses, we get called on the most is irritation around a central line. And these pictures are classic CHG reactions on infants. It was one of the things I was the most excited about when I started to learn about Vashe and understood what the molecule could do and how safe it was. And we started using it a long time ago. One of the first things we did was diaper rashes, and second was on central lines. Because your choices back then were what? We have CHG, we have betadine, or we have saline. And Dr. Amaya already spoke to, you know, how saline isn't going to really do anything. If you've ever heard Dr. Joyce Black talk, she's a wound care phenom, and I have to borrow one of her analogies, is that if you're using saline on a wound or a skin issue, you might as well be anointing the bacteria. You're not going to help anything in the situation here, and it's not going to calm the skin down at all. You oftentimes can't use your traditional CHG gel or other dressings or biopatches on these kids either when they've got this bad CHG reaction. So we have actually developed an alternate central line dressing, and there are things that you can do or not do depending on what the issue is. If it's just medical adhesive related, is it CHG? Is it a combination? What is the problem? We've done this again for almost a year. Our CLABSI rates are no higher with patients that we use Vashe on versus patients that use CHG. You can see our bottom bullet point there. The longest running patient that we used as a weekly dressing change and only used Vashe was 2 years. Thankfully, that child recently transitioned to a portacath, finally talked his mom into that, so he doesn't have weekly dressing changes anymore, but he did just fine because he had severe eczema and other skin issues, and he just didn't tolerate any other kind of dressing or anything else being used on his skin. For any of you that have a CV team, we have a very active and robust cardiac program at Dell Children's, and our team members, the physician assistant and the nurse practitioner who do all of the LVAD and Berlin type dressing changes every day, they tell me that they use CHG on an LVAD as a first go around. If there's any issue with the CHG being tolerated by the child, they will switch that LVAD to Vashe without any question. On the Berlins, which are cannulas that are drive lines that are going into an infant, not talking an open chest here. I will leave that to the surgeons, but the Berlin devices, they feel like they can't adequately get around the skin and clean as well as they need to with a CHG wand. They just can't get it. And so they've always used and only used Vashe on all those lines. And they were thrilled when they learned that we could warm it, because now those babies tolerate their dressing change just fine without pain medication. They do great with it. Daily bathing. Obviously, if you've got a central line, you have to do daily antimicrobial bathing. So it goes hand in hand. If you can't use CHG, then for the dressing change, then obviously you probably can't use it for the bathing either. So on the infants that are old enough or older children, obviously that's no issue. We can do it. And then a couple of years ago, our multidisciplinary NICU council that's across all of our network are wonderful, came together, and they came up with a bathing guideline that incorporated Vashe into that. So if the infant's not tolerating it, or if they're too young and they feel like they need to use something, then Vashe is part of that protocol or guideline. I know Ergo has guidelines and algorithms from other pediatric and NICU places that they can share with you as well. So don't feel like you have to invent the wheel. There are other people besides just us even who are out there doing it, and we're happy to share if it can help someone. Obviously, these are not neonates, but they wanted me to address like chronic conditions when you're using it long term. This unfortunate child on the left was a 12-year-old with spina bifida. Her dad didn't realize that the cushioning on the back of her special chair had was not working anymore, and her coccyx was actually sitting on the frame below. And the way that he lifted her in a Hoyer lift to do all her cares and stuff, he didn't know till he got blood that she had a stage 4 pressure injury. So the first picture is after surgical debridement, which they did one time, and then they said she's too high risk. So literally what we did is we did Vashe cleansing and packing what to dry with this with Vashe. This was probably 2 weeks later, how much it has cleaned up and how it's granulated, and a lot of that non-viable tissue is has debrided with the Vashe. She was discharged home and lost to follow-up. Driveline sites. This is one of our first left ventricular assist devices 8 or 9 years ago, and this was a 12-year-old. They called me 2 weeks into it and said, you know, she is not tolerating CHG or betadine. And not only that, but this is what our driveline site is looking like. That was a lovely hole that I have no idea how deep it was. I wasn't going to probe it since it went to her heart. If you don't know what an LVAD is, you can't, it's not like a central line. You can't just take it out and put another one back in when the infection is gone. We had to deal with this issue. And so I said, well, the only thing we can use on it is the pure hypochlorous acid, the Vashe. This was before we knew we could warm it at all. So this 12-year-old had it at room temperature and she tolerated it just fine. And she goes, that doesn't bother me at all or hurt. The second picture is 2 to 3 weeks later. It made it literally, she had the nutrition, everything was there. We just had to quit using products on that site and that wound that were killing all the good cells. So we were able to get the Vashe down into that hole and let it, you know, work on any pathogens that were down inside there where we couldn't see it, and it healed right up. She did great. She transitioned to her heart transplant 7 or 8 months later, I believe. Mom went home and they only used Vashe on her. This is also a daily dressing change. They only used Vashe the whole time that she had that line in. Okay. So obviously we use this on all of our patients that need it, and the more complex they are, the more likelihood they are to have Vashe. It's really exciting to me when parents come in with these complex children and we pull out Vashe and they already know what it is. It's out there, it's being used all across pediatric places and more. And so we're getting into the NICU places, especially on the babies that are born with things like genetic deficiencies or epidermolysis bullosa, and you have the skin that's sloughing. I do have the question sometimes when staff first encounter Vashe and they smell it and they go, oh my God, this is bleach. It's like, no, it's not bleach. It smells like chlorine. It's hypochlorous acid. So you have this chlorine odor, but it is not bleach, and it's going to be actually very soothing to the skin. It's not going to it's not a bleach product. There are products out there that are combination that have hypochlorite and hypochlorous acid in it. So the hypochlorite again is very cytotoxic to cells and would not be safe on a neonate. So be cautious of the products that try to mimic pure hypochlorous acid. So I'm not sure why bullet point 1 is in blue, but these are all equally the same. Ergo asked us to speak to how do you advocate for Vashe, or how can you advocate for Vashe in your hospital? I feel very fortunate that I was really met with open arms when I brought Vashe in and started introducing it across the specialties. But I know from talking to other wound care people at conferences that they have not all had that same advantage. So these are just some of the pearls I have come away with after a decade. First of all, shout out to Dr. Amaya. Talk to your infectious disease practitioners. They understand the science, they understand the evidence, and they're going to be great advocates for you no matter what, you know, if it's a council or specific specialty or specific physician, they can help you bring it in. I would also add in here on dermatology from a pediatric standpoint, because we do so much with them and work so closely with them. And they were certainly one of the early adopters when I talked to them about Vashe and hypochlorous acid, and we all started learning together about it and have grown with its use over this past decade. Make sure you show them the evidence. A decade ago, we didn't have a lot. There's more and more and more out there now from not only Dr. Amaya and myself, but lots of people are out there. There's way more than was out there a decade ago. So ask your ergo representatives. They can help you with that. Start with lower risk things. That's how I did initially, is before I really started spreading the word, is I had to use it and get my confidence up in it. So I started using it on things like diaper rashes and irritations around trachs and G buttons, and had phenomenal results. And so then as I learned more about it, and we spread it on, and that's how we started using it on central lines and drive lines and all the other things that we now use it on with great confidence and without any side effects. I'm talking about the last two things here, teaching like the mid-level people, your nurse practitioners, physician assistants, and teaching your staff, nurses, and your parents. Not to say you don't teach your physicians, but if you're like us in our teaching facility, we don't get to see the attendings all that often, or the surgeon or the oncologist. So it may be the people we see more often who are going to interact with them are all of these other people. And as we taught them about it, then they also help spread the word. And especially if there was anyone who was a holdout or hesitancy, I think that's another way to get them on board with that, because pretty soon as it starts to spread and they see the positive results, they're going to get FOMO and they're going to want to be part of it. And you'll get them on board, hopefully. Now, patients, hopefully in the NICU, you're not going to have a patient talking to you. If a neonate starts talking about Vashe, it'll be a TikTok moment. But in other settings, when you have older patients who can talk and advocate, we've had older patients just say, "Where's the Vashe? You're not touching me with anything else." But so, and we've had some funny things kids have said also. All right. I am going to turn it back over to Dr. Amaya.
Thanks, Carol. What a great presentation. And I know a lot of people had questions that regarding the use of bathing and central line applications. I know I do. So hopefully Nan and Ergo can have access or be able to provide links to help you all with those questions as well. So when I going over my cases, I wanted to focus on as non-acute or non-complex wounds as much as possible, because for the most part, the bedside nursing and nurse practitioners aren't necessarily managing these. I wanted to focus more on something that was simple and that you interact with and what I deal with every day. And what I wanted to focus on, diaper dermatitis. So I've given this lecture to various groups before. It's a common problem. I see it every day, unfortunately. About 4 years ago, I went to SAWC, which is one of the big national wound conferences, with the idea in mind, I need to find myself a new barrier. Because we were having major problems with skin breakdown, especially in these micro preemies. And I said, I need to find what's the latest and greatest, because whatever we're using is not working. And lo and behold, I sat in on a Vashe lecture, and I realized it was like a light bulb moment. And I said, of course, why aren't you using Vashe to this? Because when you think about it, when you think about diaper dermatitis, everyone focuses on the barrier. How can we prevent the barrier to affect so the stool doesn't keep irritating the skin? But then when you think about it, no one's actually talking about the wound itself. What are we doing about the wound? And sure, zinc oxide has some constricting effects on the skin itself and helps to dry out some of those wounds. But no one was really talking about the wound itself, more the barrier. So then I took it upon myself, you know what, this is a great opportunity to start talking about Vashe for simple things like diaper dermatitis that everybody else deals with on a daily basis. So like I just mentioned right now, whereas the barriers are important for avoiding additional irritation of the stool and urine to the skin, we want something that will promote the skin irritation for healing. And that's where Vashe came in, and hypochlorous acid. So I started using it to help promote the wound healing with changing the pH, as well as the antimicrobial effects, because as you well know, yeast is a major factor on skin breakdown and contact irritation, leading to diaper dermatitis, as well as some staph and strep species as well can come into play. So we threw together a simple protocol that basically applied for severe cases of skin breakdown. We said, okay, everyone's going to start applying Vashe, the nursing staff rather, is going to apply Vashe to the babies affected diaper dermatitis. You're going to do it once per shift. You're going to do it anytime during the shift. I was trying to make things as simple and as uncomplicated as possible for these bedside nurses. And I said, you're going to, next time you do an assessment, you're going to do your routine care. You're going to apply Vashe to a gauze. You're going to stick it in the diaper, leave it in the diaper, walk away, do your charting, do whatever you need to do, 5-10 minutes. There's no magic time, but at least 5-10 minutes of Vashe in direct contact with that skin. And then take your gauze out and then apply whatever barrier you were using. I didn't change specifically the barrier that was being utilized. I just focused on the Vashe itself and how well would Vashe work with barrier X, Y, or Z. And then lo and behold, I think the next slide shows it better. Yeah, so within 7 days, we had nearly 100% of these babies went from complete irritation down to healing wounds. We had one baby that took a little bit longer. She had more severe skin breakdown. But for the most part, the most important factor on here was the fact that I didn't really change the barrier. I just changed the method of applying Vashe to the baby site. Now, in the big picture of things, you also have to remember that now everybody's focused on this baby's bottom, right? So everyone's really paying attention, and maybe that more attention to the baby's irritation help improve just bedside care for that matter. And then I recognized that there were some babies that maybe there was more an infection present that needed a topical or a systemic antibiotic or antifungal because of the severity of it. But this has been more of a standard of care now. The nursing staff knows that if it gets really bad, then we're going to start applying Vashe. And like I said, I've kept it as simple as possible, 5 to 10 minutes anytime during your shift. And we have had excellent outcomes. And now, I mean, we had 10 patients for this study. Now we're working on patient a gazillion and one because literally we see this every day. Then the Ergo and Vashe kept on saying, well, Dr. Amaya, we really want you to do more studies on this specific condition or that specific condition. And I really took a step back and I said, you know what? The only problem as I have as an independent practitioner assessing this product, you really don't have very good data to suggest safety in preemies. And when I started to look into it, some of my closest friends that are in pediatric wound care had published data on this, but literally it was maybe 2 cases where there were a few babies. I think it's on the next slide. Yeah, on the very bottom. The current literature showed there were 5 premature babies on one report and 1 premature baby on another report, and the other ones were pediatric. So yes, adult literature has excellent studies on safety and efficacy of Vashe and hypochlorous acid in their patient population, but no one really had focused or published anything yet on premature babies. Was it safe? Was there any adverse effects? We knew the practical answer. We've been using it for years. Carol's been using it for 10 years, but there was really never anything to say, okay, here's the foundational study to do this. So we end up doing an inclusion, a study. This is work in progress. We're publishing this very soon, hopefully. So we went back and looked at all the babies we ever took care of, we wanted to get about 100 babies. And that took me about, we started the study was from 2022 to 2025 as retrospective, but we only went back less than a year because we had that many babies where we used Vashe on. And the general patient population ranged from 21 weeks where I applied Vashe to term babies. We had all types of wounds, IV extravasation injuries, contact irritation, post-surgical complications, pressure injuries, skin tears. I mean, the gamut of acute wounds in the NICU population. And we wanted to make sure we included babies that were in isolate, they were intubated, where are the antibiotics, were they getting other types of dressings on their wounds itself. We wanted to make sure, were there any adverse effects as a complication of being in that type of environment or cofactor. And what did we find? We found none. So this is published work in progress. Hopefully have that out, and this will be a kind of a baseline for everybody. But we've had no evidence for complications of Vashe on premature infants going down to 21 weeks and as small as 340 grams, and no adverse effects, no complications or anything like that as seen with Vashe on these babies. So hopefully that'll be the standard of care that everyone can rely on to say, yes, this is a safe product. And now we can start studying it for other specific studies and situations. But that's hopefully something we'll be getting out in the world pretty soon. So let's wrap it up. So we can say that how do you eliminate the process variation? Well, we implement evidence-based care. We standardize the process. We implement evidence-based custom protocols based on your NICU needs and hospital facility guidelines to try to use Vashe for these babies that Carol and I have just shown how safe and effective it is on various types of wounds in the neonatal patients. And you don't have to have hardcore, terrible wounds. You can have simple as diaper dermatitis that to any mom out there is just as important for their child as the baby with an open chest wound from a cardiovascular case, right? So Vashe would be the great option for you to have in your unit. Standardize this so that we can use it throughout the hospital. I know multiple we just found out that a post-surgical unit in one of the hospitals we're at had the big old bottles, and we're like, man, we want some of that. And that just goes down to communication, communicating within your own hospital to know that we use it well, and everybody should use this for their surgical wounds and their complex wounds. And empower the staff. We definitely have empowered our nursing staff and to be the forerunners to say, hey, Dr. Amaya, this might be a case where you need the Vashe. And like, by all means, let's start that. And you know where the bottles are, and let's get started on that. And of course, we keep track on who's receiving what. We don't want to be all willy-nilly with application, but we want to know that nurses feel comfortable using it and that the mothers recognize that we're only doing the best and the safest options for their babies. And I think that might be, another important thing. So babies get discharged, right? Kids get discharged from the pediatric units and the PICU and the NICU. And how can parents get a hold of this on their own? By all means. I gave a lecture to another group of young moms to put this in your first aid home kit. And Vashe is available over the counter. And that little QR code can get you the Amazon link, but Amazon sells everything. So you can find regular Vashe on there too. But Vashe has an over-the-counter formulation and definitely should be part of everyone's little first aid box that they have in their home for every type of minor emergency, to burn, to cuts, etc. We all live in a real world, and Vashe would be a definitely part of that toolbox needed. But that it says available in stores at Walgreens, so that's great. But I know everything's on Amazon, and you guys are on Prime. You can get it the next day. And I think that's it. So I think we're going down to questions. I think we talked a little more than we thought we were going to talk about, but if I'll divert back to the NAN staff to decide what kind of questions you guys want to ask.
Yes. Thank you so much, Dr. Amaya and Carol. So we did go a little bit over, but we have time for a few questions. And in case you missed it in the chat, if there were questions that we aren't able to get to, we'll be putting together a little FAQ to share with everyone who's registered so that we can make sure we're answering all of your questions. So the first one we have was, has Vashe been used to prevent skin breakdown from G tubes or trachs?
By all means, I think Carol brought that up, and I've used
Yes.
it routinely. So Carol, you can comment more about it, but yeah, that's been a routine for all our cases.
Yeah, we use it routinely, and again, the staff don't need an order. We have ENT follows all of our trachs. Surgery, we kind of divide and conquer on the G buttons because they're everywhere. But again, staff can grab a bottle of Vashe and use it at any time, and we all use it.
Great. And then can Vashe be used as a skin prep agent prior to a procedure, such as a central line insertion, instead of using CHG or betadine?
I'll defer to Carol to that. She's been more the expert on the central line placements.
Yeah, to my knowledge, I don't know that any of our surgeons or people placing lines are using it for the actual insertion yet. I think they still will use betadine over CHG and then rinse it. But then once that line is in, then Vashe can be used for every dressing change after that. But I'm not aware that anybody has gone to using Vashe as a skin prep just yet. And
Okay.
I think that's just the unknown. I think, that first do no harm, they're just not sure. I don't think there's any reason they can't, but I don't put in central lines, so I don't have any jurisdiction over their decision.
Okay, kind of a follow-up question to that, and I'm not sure if we have the answer, but are you recommending using Vashe as the cleanser for central line dressing changes instead of betadine or CHG routinely?
We have no hesitation if there's an issue. I think our standard is still, because that's what's been out there for so long with the proven efficacy, is the CHG. But there is absolutely no hesitation. Our infection prevention department, our infectious disease physicians, everyone has condoned the use of it with any kind of dressing change. And when there's any kind of skin issue, it's like, stop doing harm, go straight to the Vashe. We have a central line troubleshooting algorithm, and we have multiple different orders with pictures and step-by-step instructions, because the staff, if they're on nights or weekends, we don't want them to put the same thing back on and keep causing harm. It's out there. They can grab it and use it, use those alternate methods to do an alternate dressing, and not wait for us to come and look at it on Monday morning. So we condone it as an absolute secondary. And like I said, the CV surgery folks who do the Berlins, that's the only thing that they use on those lines. So I think it's been proven to be safe, but I think as the overall hospital approach is still the CHG is the standard, but nobody has any hesitation to use the Vashe.
All right. And then last question that we have time for today. Is there any benefit or increased risk to using a Vashe wipe every diaper change?
Definitely not. I don't see any problems with that, with the safety or efficacy. I think it would only benefit the baby. Whether you need it or not is a different story, but I don't see any reason why it would be having the adverse effect toward application.
Agree.
We've reached the end of our hour today, and this concludes our presentation. But thank you all so much for joining us. Thank you to Ergo Medical for putting this together. And last but not least, thank you to Dr. Amaya and Carol for joining us and educating us all on this